assist you. Okay, as I mentioned earlier, our speakers tonight are Dr. Sunita Kulshrestha, and I apologize. I have a very difficult time pronouncing her name, and I
not a problem. Everyone calls me Dr. K, so feel free.
There you go. I feel bad. And also Phyllis Lowinger, MED, LCSW. As I mentioned, they're both affiliated with the Genetics and IVF Institute in Fairfax, Virginia, and they will be presenting information on the topic of extending your fertility through the use of donor eggs. They're also going to provide the audience with a short synopsis of their background at the beginning of each of their presentations. So, ladies, thank you for sharing your knowledge and your insights on this topic this evening. We really appreciate it. We'd also, again, like to thank the Genetics and IVF Institute for sponsoring the webinar. So, Dr. K, at this time, as the first presenter, I am happy to turn the floor over to you. Just let me know when you need me to turn the pages, and I certainly will.
Absolutely. Well, thank you, Dawn, and good evening, everyone, and welcome. Thank you for sharing part of your evening with us. As you know, my name is Sunita Kulshrestha, also known as Dr. K, and I'm a board-certified reproductive endocrinologist and infertility specialist. I've been with the Genetics and IVF Institute in Fairfax, Virginia for over the past 10 years, and the topic of my presentation is the use of donor eggs to extend fertility. Next slide, please. Oh, actually, you're already on the first slide. Thank you. Before we go into the details of the use of donor eggs, let's step back for a moment and go over some basic points about infertility. Infertility is defined as the inability to conceive a child with over 1 year of trying for a woman who is less than age 35 and after 6 months of unprotected intercourse for a woman who's over the age of 35. There are certain situations, however, when a woman is known to be infertile from the very beginning. For example, a woman who is menopausal or at a significantly advanced reproductive age. Next slide, please. Infertility is common. Approximately 1 out of every 7 couples is infertile. This means there are approximately 7 million infertile couples in the United States. Infertility, as a result, is the most common medical problem affecting people between the ages of 25 and 50. Next slide, please. The causes of infertility are multiple. They include male factors, female factors, combined factors, and unexplained factors. Of the causes of infertility, female factors comprise 40% and may include problems with the egg, with the tubes, with the pelvis, and uterine factors. Of the female factors, the one we will be focusing on today is infertility due to problems with the egg. Next slide, please. The treatment of infertility through the use of donor egg as it relates to advanced reproductive age or decreased ovarian reserve is common, partly due to the changing demographics of the infertile population. Women as a whole are delaying the age of childbearing. This is partly due to changing roles and aspirations for women, both professionally and personally, postponement of the time of marriage, and more second marriages. Additionally, with advances in technology and insurance coverage and awareness, infertility treatment in general, and now more specifically the use of donor egg, has greater awareness and accessibility. And now also it's the best time in years in the sense that success rates are higher than they've ever been before and continue to only improve. And so previously thought cases that were thought to be challenging or impossible are now having success. And so it's a wonderful time to be considering or pursuing this, both as patients as well as professionals. Next slide, please. The issue with aging is that pregnancy rates do decline with advancing age. A woman's fertility is maximal up to about the age of 32. And starting at that point, pregnancy rates start going down. It might be a little hard to make out from this graph, but if you pay attention to the middle line, the one in the gray, for example, at the age of 40, using own eggs, and this is data with IVF, which is the most efficient way of achieving pregnancy, At the age of 40, pregnancy rates are about 20%, compared to in the 20s, 50+%. At age 44, we're down to less than 5%. At age 46, we're down to 1%. And so as you can see, there is that decline, and that decline becomes much more rapid starting at about the age of 38 and definitely between 40 and onwards. And so why is this the case? Next slide, please. As a woman ages, there is a natural depletion of oocytes, also known as eggs. For example, at birth, a woman has about 2 to 3 million eggs. When her period starts, at that time it's already down to 400,000. So this is not about releasing only one egg a month. Every day, throughout the month, there is a loss of eggs. And then the decline continues. Next slide, please. It continues to the point that at the age of about 37 and a half, a woman has about 25,000 eggs. And at the age of about 50, 1,000. Next slide, please. Some people will ask, well, if at 50 I have 1,000 eggs, all I need is one egg, to have a good baby. Number is one thing, but egg numbers are not enough. Egg quality is also very important, and quality is defined as the ability, molecularly and biochemically, for the egg to lead to an embryo that will implant and lead to pregnancy, and that does decline with age. And then the other factor that's very important is the genetics of the egg. As a woman ages, there is a greater chance of chromosomal abnormalities occurring in the egg. And this picture here shows you an example of what I mean by that. The top two, upper left and upper right, are eggs from 20 to 25-year-old women. And if you look at that line, that symmetrical line with the red, that is basically part of the meiotic spindle assembly. And what that pretty much is when eggs go ahead and get ready for fertilization, and then when they fertilize and the DNA comes together and splits, it should be lined up orderly. The split should be nice and even, and that's how the chromosomes are lined up in the upper two figures. In the lower, bottom left and bottom right, that same sort of line that you can go straight through, you see the red kind of all over and dispersed. And so things are more disordered. And as a result, that egg is more likely to lead to an embryo that's aneuploid. Aneuploid means extra DNA. For example, sometimes aneuploidy can lead to actual chromosomal abnormalities and birth defects, like an extra chromosome 21 is a Down syndrome. Sometimes there can be multiple abnormalities, and so at that point, the embryo just simply doesn't function or attach. As an example, at the age of 40, about 80% of embryos are aneuploid or chromosomally abnormal. Again, that does not mean that that's going to lead to that much greater risk of birth defects. Most of the time, this just means that that embryo just wouldn't lead to a pregnancy. Next slide, please. So this is where donor egg comes in. If we look again at the graph that I showed you earlier, the green plot at the bottom being how pregnancy rates go down as a woman gets older. Now we can pay attention to the upper line, the blue that goes straight across. And this is what pregnancy rates are when women use IVF with the donor egg. As you can see, pregnancy rates are pretty stable with that nice line that we just drew across, meaning that a woman at age 28, 36, 46, even up to 47 plus has a stable pregnancy rate when they use donor egg. And in other words, what we're saying here is a woman who is 47 using donor egg has the same pregnancy rate as a woman who's 27 using her own eggs. And so it's pretty amazing and impressive how donor egg can really bypass any of the concerns with advanced reproductive age, poor egg quality, or inability to get pregnant because of compromised egg quality. Next slide, please. So who are the patients who pursue donor egg or oocyte donation? Women of advanced reproductive age, and that term, is unique to a specific person's situation. For some people, they want to pursue a cycle that will give them the optimal success rate, so they might consider donor egg as early as, early 40s. Other people, older than that. Women who are perimenopausal, women who are menopausal. Even a woman who is menopausal who's not had periods for 10 years can use donor egg. The medications that we use, which I'll get into shortly, actually mimic the body into thinking that she is having normal, regular cycles, and hormonally is the same as she was prior to reaching menopause. Women who have premature ovarian failure, whether it be that they have ovarian failure for unknown reasons, for genetic reasons, or because of chemotherapy or radiation therapy from cancer treatment. Women who are known to have poor egg quality, be it from looking at the eggs when they do IVF and the eggs are visualized, or whether it be presumed poor egg quality due to tests of ovarian reserve, as we call it, tests to evaluate egg quality, whether it be blood tests that are in use such as FSH or another blood test called AMH, or looking at their pelvic ultrasounds. And women who have repeated IVF failures. Studies show that if people get pregnant with their own eggs, they usually get pregnant within the first 3 to 4 cycles. So even women sometimes who are in their 30s, and if they've tried IVF 3 times, 4 times, at that point, if it has not been successful, sometimes think about and move on to donor egg to be more efficient. And another reason to pursue donor egg is if the woman carries a genetic disease and it's thought that the child is at risk of having that significant disease, donor egg will bypass that as well. Next slide, please. Now, egg donors can be classified in a variety of ways. The most common is the anonymous fertile donor. These are women who cycle through either a fertility center or an agency. They're women who are pre-screened and selected and go through the IVF process in order to give the intended recipient eggs, and it's generally speaking anonymous, confidential, and of course legal. Another approach is using known donors. Known donors can be either family members or friends. Once these designations have been made, there are other designations that can be used as well, whether it be anonymous donor or known donor. A cycle can be a single cycle, meaning every single egg that the donor produces goes to the intended parent. It could be a split cycle, where the number of eggs that are obtained are then divided between a patient and another party. And then donor egg cycles can be fresh, meaning that the donor intentionally is recruited to do an IVF cycle, and that cycle is synchronized with the recipient in real time. Or it can be using frozen eggs. And frozen eggs, the term for it scientifically is what's called vitrified eggs. The use of vitrified eggs is a relatively new technology. The use of fresh donor eggs has been around since the 1990s. But for years, the egg was actually quite particular and finicky, if you will, in terms of its ability to survive the freeze-thaw process. Recent advances in the lab have now made egg freezing a possibility. And so now there are some donor egg banks across the country. We have one as well, where that's another option in terms of the source of eggs. Now, the pregnancy rates depend on who donates the eggs. And ideally, a younger woman is better than an older woman, and a younger woman ideally is a woman up to the age of 32. And anonymous donors tend to be more fertile than a regular family member or friend. And the reason is that, generally speaking, anonymous donors go through much more rigorous screening. Next slide, please. Now, the donor screening that is conducted varies by program. And I can give you a list here of the general categories which are done and tell you specifically as well, for example, what we do at GIVF. Generally speaking, we start with the medical history. That includes general health, gynecological history, obstetric history, and a family history. Then a comprehensive physical exam from head to toe, checking their lungs, their heart, their breast exam, their pelvic exam, blood pressure, pulse, etc. Blood work, which includes checking their thyroid, checking cholesterol level, and tests on egg quality, including day 3 FSH and a pelvic ultrasound to see how many small follicles that they have, known as antral follicles. Genetic testing is also done, and again, some programs tend to be more comprehensive than others. The most comprehensive panel includes a karyotype, which is a blood chromosomal analysis, looking at the structure and number of the chromosomes, which are the packages that contain the DNA, screening for Fragile X, which is the most common cause of inherited mental retardation, screening with a hemoglobin electrophoresis, which looks for genetic causes of anemia, and screening for cystic fibrosis, which is a very common disorder in the Caucasian population that can be inherited, and then a review by one of our geneticists looking at their family history. We also do infectious disease screening, as everyone in the country does, and that is regulated by the FDA. The infectious disease testing includes hepatitis A, hepatitis B, hepatitis C, HIV-1, HIV-2, gonorrhea, chlamydia, syphilis. There have been no reports of transmission of infectious disease through the use of donor eggs. Psychological screening is also done, and that includes screening to ensure that the donor does not have any obvious personality or mood disorders, that they're well-informed, responsible, and that they're doing this for the right reasons. Random urine drug screening to make sure everything is normal with that. And then overall, good screening means that you have a quality donor. And then within the program itself, up to the program to maintain measures of quality control, to pay attention to the donor cycles. How many eggs, how many embryos, what was the quality, did it lead to pregnancy, and maintain their own vigilance in making sure that the donors that are in the program are high-quality donors that lead to pregnancies and babies. Next slide, please. As I mentioned a few minutes ago, the donor infectious disease testing is regulated. The FDA is involved with the screening of the donors, and the specific tests that are used for infectious disease testing must be FDA-approved tests that are done in specific labs, and they must be done within 30 days of the egg donation, meaning that even if a donor has had 4 or 5 tests for HIV or gonorrhea or chlamydia in the past 1 year, when it's time for her to donate to the intended party, everything has to be repeated. And a lot of the tests are DNA tests, which are the most sensitive and accurate tests available. In addition to the blood work, there are lengthy questionnaires to assess high-risk behaviors to rule out any possible theoretical transmittable disease, and a repeat physical exam that the donors have to have every 6 months. And so, for example, if donors have traveled, to certain countries for vacation, and that country has been known to have a mad cow disease outbreak, that donor would be excluded from the program. Or say a donor had a DUI and had to spend a night in jail, she would be excluded from the program because, again, it's not that these are potentially high-risk behaviors for infectious disease. And so patients can be very comfortable with that aspect of the screening. Next slide, please. Just as the donors have testing that is done before they do a cycle, so does the recipient. The recipient's screening also begins with a very thorough medical history and a physical exam. If she's known to have any medical conditions, the goal is to optimize those medical conditions for her to be as healthy as possible prior to doing a cycle. We then recommend a uterine cavity evaluation to make sure the uterus is normal, making sure there's no fibroids or polyps or scar tissue. And the uterine cavity evaluation can be done either through a test called a hysterosalpingogram, also known as an HSG, a hysterosonogram, or a hysteroscopy. On the male, we also do a semen evaluation to look at the semen quality, and then blood work as well, again looking for infectious diseases on both partners. For the female, checking her blood count, her thyroid, her blood type, evidence of immunizations and vaccinations. etc. And then in an older woman, perhaps additional tests. For example, if a woman is between the ages of 50 and 55, a cardiac evaluation, a chest X-ray, a pulmonary evaluation, and age-specific tests based on her age as well as her medical history. Next slide, please. So now on to some fun pictures here. A semen analysis looks at the sperm concentration or count, the motility or movement, and the morphology. And the morphology is the one term that I find confuses most patients. And morphology pretty much has to do with the shape of the sperm. A typical normal shaped sperm is an oval with a bit of a taper at the end. And as you can see in the pictures that we have here, we have some sperm that have large heads, like the one that we've highlighted now. We have double heads, like the fourth sperm. There are sperm with like double tails and so forth. And if the sperm morphology is not normal, if the sperm motility is low, these are things that can affect and compromise fertilization, in which case we later use a technology called ICSI, and I'll show you a slide of that in just a little bit. Next slide, please. When we take a look at the uterus, as I mentioned, we want to make sure that within the uterine cavity there's no polyps, fibroids, or scar tissue. And this is a picture of a sonohystogram, also known as a saline ultrasound. And the black in the central is the uterine cavity. On an ultrasound, clear fluid, like saline solution, is black. And it should have just been a simple black circle. And you can see that there's that white structure coming off at about 9 o'clock. That ball there, that's a patient that has a fibroid in the uterine cavity. So by simply putting in the fluid through the vagina and then doing an ultrasound afterwards, the uterine cavity can be assessed. And the uterine cavity is the part of the uterus where the pregnancy grows. The other parts of the uterus can also be visualized, and that includes the muscle of the uterus and the outside with the ultrasound. Next slide, please. Now, what does the IVF process involve for the donor? In IVF, the donor takes daily injections of hormones from anywhere between 2 to 4 weeks. They're small needles, smaller than a blood draw needle, and one type of medication that's used is a medication to turn off her body or suppress the ovaries. The purpose of this is to prevent early ovulation. We want the eggs there waiting for us when we go to retrieve them, and to minimize any hormonal changes. Beyond the suppression phase, we then move to stimulate the ovaries to produce multiple follicles, which are the homes of the eggs. And the medication that's used for that purpose are the hormones FSH and LH, which are natural hormones normally found. And after the follicles have been stimulated to form, we then proceed with an ultrasound-guided egg retrieval. Next slide, please. Here are some pictures of ultrasound images. On the left is an image of an ovary with the follicles that are starting to form. The follicles are those big black circles. They're the homes of the eggs. You can't see the egg other than when they're retrieved under the microscope, but you can see the follicle. And on the right is a picture of the uterus and the uterine lining. And that central portion in between the two white calibers is the endometrium. That's the portion that we watch and we stimulate and we wait to thicken in the recipient. And this is an ideal image of an ideal uterine lining. You can see those 3 lines in the center, and that's called a triple pattern. Next slide, please. Once again, this is an image of a stimulated ovary with multiple follicles. This is an ovary that has at least 10 follicles in one image, probably even more behind. And when we do a retrieval, the needle pokes into each of the follicles, and that's where we retrieve the fluid to hopefully find an egg. Next slide, please. The retrieval is done often in an office setting. The donors get medication through the veins so that they are asleep and pain-free. And an ultrasound is used through the vagina, and there's a needle that passes along the ultrasound probe into the ovary and directly into the follicles, and the fluid is collected and handed back to the lab. It's a quick procedure. It takes about 15 minutes to do. Next slide, please. Now, while this is going on in terms of the donor stimulation, the recipient is also being synchronized with the donor. so that her uterine lining or endometrium is prepared to receive the embryos. She also has downregulation and suppression of her hormones, generally with the use of a medication called Lupron or leuprolide acetate. It's an injection, involves usually taking an injection 1 shot a day for about 4 weeks. The purpose of turning off the body is so that both the donor and the recipient can be synchronized. So the embryos think hormonally they're coming out of one body and going into the same one again. Also, we wouldn't want the recipient to have a period at the wrong time or her hormone levels to change at the wrong time of the cycle. After the suppression phase, the recipient then has stimulation of the endometrium, and that's by having her take supplemental estrogen. Estrogen can be taken in a variety of forms, including oral medications or pills, estrogen patches, and injections. The next phase includes taking the medication progesterone, and that's what prepares the uterine lining to secrete what the embryo needs in order to implant, and that can be through a vaginal preparation or injections as well. Next slide, please. Once the eggs are collected in the dish, the male partner's sperm is added. That's called conventional insemination if the sperm is normal, or the ICSI procedure is done where sperm is injected if we think the sperm needs some help. The embryos then are cultured in the dish and then transferred. Anything that is excess can be frozen or cryopreserved, hopefully for a future brother or sister, or if it doesn't work the first time, another chance, which is often much less expensive, much easier. Next slide, please. And again, a pictorial of what we spoke about is the first step, which is the lower left image of the egg retrieval, moving up to the upper corner on the left, which is the insemination or adding the sperm. Again, the culture in the dish. And then finally, the embryo transfer. And the embryo transfer is just like a pap smear. Speculum goes in, then small tube called a catheter that contains the embryo or embryos is passed up into the uterus and dropped off at the top portion where embryo implantation occurs. Next slide, please. I mentioned a little while ago the use of ICSI, which is when the sperm is injected into the egg. This is a picture in the middle of the egg. To the right, that thin needle is actually with which the sperm is injected. And right above that yellow arrow, you can see a little dark spot. That's actually a sperm. So relatively speaking, as you can see, interestingly, compared to the egg, the sperm is very tiny. And actually, it's the sperm that is injected into the egg, and that's what the ICSI procedure is. Next slide, please. In terms of how the eggs look, the upper left image is what an egg looks at the retrieval. It's called the oocyte cumulus complex. There's a bunch of cells around the egg that kind of fan off like the rays of a sun. Moving on to the image to the right of that, the eggs are then cleaned, and that's what the eggs look like right before, for example, we do ICSI. Moving to the lower left image, on day 1, we now have an embryo. And if you can take a look, in the middle of that egg is sort of a central double dimple. That is what's called a pronuclei. You can see that's where the genetic material is of the egg and the sperm, and that's how we can see that fertilization has occurred. The embryo then starts growing, and on day 2, off to the right, you can see that there are 4 cells, and those are pictures of a nice-looking embryo. Next slide, please. The embryos continue to grow. On day 3, an ideal embryo is about 8 cells. On day 4, it's compacting, meaning it's trying to merge together, and you lose the defining cell membranes. On day 5, the embryos are blastocysts, and that's the stage where there is an inner cell mass followed by the outer cells. At this point, the embryo is differentiated, and then eventually the embryos start hatching or breaking out of their shells. Next slide, please. Now, what determines success rates, whether it be IVF with own eggs or IVF with donor eggs? It really is a very personalized, individualized process, and success rates are related to several factors. The most important is embryo quality, and embryo quality is most related to egg quality. And that's why donor egg success rates are so high, because these are eggs from younger women who are thought to be more fertile and have better egg quality. The second factor that determines success rates is the number of embryos transferred. Up to a certain point, yes, putting in more than one embryo does give you a greater chance of getting pregnant, but again, the trade-off is the risk of a multiple pregnancy, which I'll describe in a minute. The next factor is uterine receptivity and having a good uterine environment. Having a uterine lining that's nice and thick and lush and of the right architecture and texture. Having a uterine lining and uterine cavity that does not contain polyps, fibroids, scar tissue, etc. The next thing is simply communication between the embryo and the endometrial lining. It's possible that there's a beautiful embryo, and it's possible there's a beautiful lining, and the embryo is placed exactly where it belongs. So the reason why it doesn't attach or implant all the time is because there is a complex interplay of local factors that are involved in the implantation process. And despite all the advances in technology, many things are still not known about exactly what is involved in implantation. And the last factor is the genetics of the embryos, as we touched upon before. Next slide, please. The Society of Assisted Reproduction and the CDC does publish data on national averages and individual success rates for clinics. There is typically a 2-year lag from the time the data is collected and the time it is recorded and shared. The national success rates with the use of donor egg for 2008, with an average transfer of 2 embryos in a fresh cycle, was 55%. Frozen donor eggs also have been used. These are the excess embryos that were transferred at a later date. Those pregnancy rates are lower, about 33%. Now, these are the average rates from 2008. If you were to take a look at 2011 data, which, again, unfortunately will not be available for public viewing until 2013, the rate now has increased to over 60%. And so for practical purposes, again, day by day, pregnancy rates are getting better. So on average now, it's 60% plus as the pregnancy rate with a transfer on average of about 2 embryos. Next slide, please. The most significant risk or complication of assisted reproductive technology in general, and specifically with the use of donor egg, is the risk of a multiple pregnancy. If you take a look at the pie chart, you can pay attention to the blue section. In, again, the year 2006, and these data is pretty consistent by year, 37% of donor egg pregnancies led to twins. Almost 40%. The triplet rate right next to that, 4%. Now, the goal in ART and in any pregnancy is to have a singleton pregnancy. The issue and concern with twins or more, apart from anything social or economic, is that anytime a woman has more than one, especially more than 2, the pregnancy is more likely to be born early or delivered early, and that's called preterm labor. And sometimes if the pregnancy is delivered too early, there can be significant problems for the babies, and sometimes the babies don't even make it. Additionally, with a multiple pregnancy, the mom is also more likely to have medical complications of pregnancy, such as diabetes, high blood pressure, etc. Next slide, please. As a result of the goal to try to lower the risk of a multiple pregnancy, both for the best outcome for the pregnancies as well as mom, the American Society of Reproductive Medicine has provided guidelines for embryos to be transferred for women at the different ages. And for a favorable category donor, the recommendation is to transfer 1 or at most 2 embryos. And that is a guideline in place to ensure overall safety for everyone involved. Next slide, please. Now, we've talked about the medical aspects of donor egg, and again, how the technology really has given hope and opportunity to many women, actually hundreds of thousands of women at this point in time. nationally and internationally who normally at one point in time would not have been able to achieve pregnancy, associated with more and more people doing this and the greater awareness and accessibility, come more opportunities for controversy. And so what are some of the controversies associated with the use of any kind of gamete donation, specifically donor egg? For one thing, financial compensation of the donors. The donors do participate with medications that they take for about 2 to 4 weeks, injections, in about an 8 to 10 day period of time. They have about 5 to 7 visits for blood work and ultrasound. They have an egg retrieval. An egg retrieval has risks. They're rare, but risks do occur, including bleeding, infection, injury to surrounding organs, twisting or ovarian torsion. And so, the American Society of Reproductive Medicine does believe, the ethics committee, that it is justified to go ahead and compensate the donors. Most programs give the donors about $5,000 to $10,000. The ASRM ethics committee states that financial compensation up to $10,000 is justified. However, individuals will privately advertising and are offering, $50,000 to $100,000 even have been reported. Another controversy is whether the children should be informed that they were conceived by the use of donor egg. And in the end, the ultimate choice, according to the American Society of Reproductive Medicine Ethics Committee again, is that it's up to the recipient parents, but disclosure is encouraged. Another area of controversy is a gamete donor registry. Should there be some kind of registry so that different, children can connect with other children who use the same donor, or possibly in the future wanting to connect with, the donor, and that's something else that is associated with controversy. It's that whole issue of anonymity and privacy and confidentiality versus what would be good for the offspring. And then the other issue is what should be an upper age limit for the recipient or intended parent. Most centers allow patients to pursue this up to the age of 50. There are some, ours included, that allow patients who are healthy to cycle up to the age of 55. But the issue is what should be the upper limit, and what factors should be used to decide that. Of course, medical, ability to be healthy during a pregnancy and afterwards is an important thing. Other factors, to consider are financial, longevity of the parents, et cetera, and that's another hot topic. Next slide, please. The future of donor egg. Where are we going now? Well, again, every day with improvements in the lab culture techniques, understanding of embryos and egg quality, understanding of how to select the best embryo and screen the embryos genetically. These are some of the technologies that will continually allow us to have higher success rates and, again, give women who normally would not have an opportunity to efficiently and successfully achieve a healthy pregnancy. So it's just a wonderful technology. Not only does it offer high success rates, it also lowers the rate of miscarriage. It also lowers the risk of birth defects. And so it's just a wonderful tool that we as reproductive endocrinologists have to help patients. The future also involves the use of using the vitrified, donor eggs. And what this means is it may not necessarily be, something that will be as difficult perhaps to coordinate. It won't be necessary to see, is a donor available? When is she available? Can you coordinate your cycle with her? It may not be that a patient has to fly from, Midwest to Virginia or any other state for that matter to do a cycle. At some point in time, you might just be able to order eggs from a donor egg bank. The eggs can actually be shipped to your own local hometown where your local doctor can actually go ahead and do the embryo transfer. And so it really is something which is probably going to be the field and way of the future. So on that note, I shall close here, and I thank you very much for your attention, and we're going to have Phyllis continue with her part of the talk, and then at the end, I'm happy to answer any questions that any of you might have, either through this online forum or even we can try to arrange something even privately for those who prefer that setting. So thank you again.
Thank you very much. Phyllis?
Hi, thank you. This is Phyllis Martin. I am a licensed professional counselor, and I specialize with reproductive counseling and mental health. And tonight, what I'm talking about is what is normal for people to go through emotionally when they are considering donor egg, and how to prepare yourself for that roller coaster that may be where you find yourself as you're considering this. And the reason why it's so important to know that there is a potential roller coaster and that there are feelings that you might feel very out of control, but they're quite normal, is simply because it puts things in perspective so that you can remember this is a phase that you're going through. Infertility is a phase of life that you're going through, and the options that you choose to pursue building your family, although they have high stress related to it, depending on how you manage stress, can impact how you feel as you go through the cycle. And it can also be something that helps give perspective so that you know this isn't the intensity that you're going to be feeling from here on out forevermore. It's just more intense during this phase. So my first slide, I have this sound familiar. I have this because I've heard all of these things as a counselor with folks coming into my office. And I've said some of these things because I am a former patient of infertility treatment. And so the first one is I'll do this, which might be Clomid, it might be IUI, might be IVF, but no way will I do that. That meaning something just absolutely not acceptable in my paradigm as of now as I look at things. And then, lo and behold, you find out after seeing a doctor, after certain tests have been done or after certain procedures, actually you need to do that if you want to consider a higher success rate or building your family where you can carry this pregnancy, that being donor egg. How do I grieve? How long will it take? People tend to know that there is grief work to be done when you're going to be using donor egg, and I will talk about what that grief work looks like. But there is also sort of this hurry-up feeling that people have because by the time you get to donor egg, normally patients have already been through many other cycles that have not worked of something. There certainly are exceptions where people go straight to donor egg and they've not ever had prior medical treatment, or they haven't even spent a lot of time getting pregnant because they knew that their eggs will not be able to be used. But there is still what feels like a clock, even though it's no longer your genetic clock for egg quality. So they want to know, how do I do it and how long will it take? In the same vein, there can be the, this is taking too long. I've been thinking about it for 6 months. I've been talking about it for 8 months, 10 weeks, whatever it is, and I'm still upset or I'm not excited. My husband is and I'm not ready. I just can't seem to get feeling sorry for myself out of my head, or I can't seem to get the concept of donor egg to be okay, even from people that want it to be okay, that will come into my office saying, I want to be okay with this idea, but really right now I hate it. I don't like it. I'm not comfortable. I'm upset. Oftentimes people will think because they are still feeling upset or because they think that they are grieving longer than they should, although there's no time frame, they take it as a sign that they should perhaps not be considering donor egg, or that they should not be doing it, that before I proceed, or if I'm supposed to proceed, I'm supposed to be absolutely thrilled, 110% excited. None of this stuff will get me upset anymore. And really that's a myth. It's just not the case. The next one is, so we're proceeding, why aren't I thrilled? And that's kind of echoing on what I said. I'm just not excited, and I can't seem to get there. And it's okay to not be excited. I would want each person considering donor egg that by the time they are going through some of the process, such as the beginning parts of getting medical testing, the beginning parts of looking at a donor, that they start to experience a mix of emotion, that they are both aware of any grief, any anger, any upset feelings coming up, but that they're also starting to see this small bit of hope grow because they start feeling like, wow, this might really be something we can do, and it could really be just what is the answer to what we're looking for. I can't find any donor that will work, and I'll talk about this in a moment at greater length, but this has got to do with people saying, I'm okay with donor, I don't have any grief around it, my genetics don't matter that much, I don't even like them, I'm glad this, that, and the other is not getting passed on, or I just want to focus on, having a baby, and so I don't really care, this emotional stuff isn't bothering me. But every time I look at the donor registry, I can't find anybody. Nobody will work. I've had clients completely obsessed with different aspects of a donor. It could be intelligence, it could be SAT scores, it could be certain looks or height and hobbies, and just nobody fits the bill. And if that tends to happen every time you look at your registry, or if you've even gone out of an agency or out of your clinic to find a donor and still no one's fitting the bill, that's normally a red flag that says, we need to slow this down a little bit and see what really are you looking for and what's blocking you, what is getting in the way, because you're not going to find yourself. And that, I think, is one of the biggest grief issues there are when we're looking at doing donor egg, and that's one of the biggest sort of awakenings that people will tell me they've had when they're looking at anonymous donors, feeling like, all right, we'll just find someone that's kind of close to me or sort of second best, and then lo and behold, she's not there because truly you're still looking for yourself. And that's the piece that needs to be resolved before continuing on. Next slide, please. This is a cycle of grief, and this is something from Kubler-Ross from the 70s, which applies to, initially, it was thought to be applying for death. When somebody dies, this is what we go through. It's been changed and modified over the years depending on truly what it is that we're grieving, because not all of our grief has to do with death. When we're looking at using a donor egg, if we're looking at anonymous or known, there is still the death, if you will, of the fantasy child. The fantasy child is the child you always imagined you would have, or that you and your partner had, talked about and played around with when you were talking children early in your relationship. And that piece, that fantasy, if you will, that for many, many people really does feel like a death, and it needs to be mourned. It also feels in part like a death for women giving up their genetics, because we do identify ourselves with our genetics. We identify ourselves in many, many ways, but certainly there are aspects of how we look and how we operate in the world, whether we know if they come from genes or not, that we just identify ourselves with. So when we're not able to use our genes, it can really throw a person, and you have to think long and hard about what does continue if I don't get to use this part of me that I thought was so crucial to who we are. So in hearing this information, I've got to use donor, or I shouldn't even say I've got to, because it's always a choice. But the choice to use donor does mean that you're going to start off somewhere probably in the denial or anger area. Shock is part of that. Shock that you're getting this information from the medical staff. Shock that you have to consider this if you want to consider a pregnancy. Shock that it's you, that you can't believe it, and it's not fair. All very, very normal. The next thing, and it doesn't tend to go in this nice, neat circle, as you see, but the next thing would be anger, that you're angry. You're angry you have to give up your genes. Sometimes women are angry because they feel like they've got the better genetic material in their relationship compared to their husband, and it's not fair. He gets to use his, and he's not doing all the work. I have to be the patient. I have to take the shots. It's not fair. Or my genes are better. We're better looking. We're smarter, whatever the case might be, and anger. Anger can also be toward the doctors. It can be toward the God or a higher being. It could be toward just sort of the overall unfairness of all of this. But it has to eventually turn into something else, or you'll be stuck. And a lot of times it'll turn into some bargaining. Those can be sort of those desperate attempts like, maybe I'll just try my eggs one more time despite getting a 5% chance, and that'll work. Or if I do everything right, and I eat this way, and I meditate, and I do yoga, and I, follow a strict diet in something or other, then it'll work out and my eggs will come back and be of good quality. And so there can be some hanging on to your own eggs and your own genetics, therefore, and kind of making these bargaining things in your mind. There's also the, I just keep having sex and hoping that it's going to work, and maybe, my higher power will allow this to happen if I'm a super good person. And so all these things, they're just normal thoughts. They're normal thoughts. What happens sometimes in the middle of all of this, as the shock slows down, as you're slowly beginning to see that this is the new paradigm in which you're going to be operating in order to proceed for fulfilling your family, depression can set in. What does that look like? Not necessarily clinical depression where you can't get out of the bed or function and you can't stop crying, but it could certainly feel like you're under a blanket. You're kind of in a cloud. People have said that they just sort of feel like they're walking around in a daze, and there's a heavy weight of sadness as they contemplate all of this, that there's sadness about what they're giving up, there's sadness about how difficult this whole thing might be financially, socially, within the marriage, or within your own sort of psyche. And for women that are doing donor egg because they're at a place where they want to be having children but they're not with a partner, that's also another very hard time, because they're usually okay with the idea at a certain point that they'll be using donor sperm. It wasn't what they signed up for when they thought down the road I'm going to be married, having kids, and it didn't work. But they're getting their head around donor sperm. If you have to use donor egg too, because you're going to be a single mom by choice, that can be a really hard blow to take, and will often stop people really kind of dead in their tracks as they go through some of these things in the grief cycle. But eventually, the idea is that you begin to understand that everything does not stop with a genetic loss, and that indeed this can be a fabulous way to build a family, and that there's a slow acceptance of this paradigm that is really a paradigm shift, going from sort of the fantasy biological child that you and or your husband have to the new fantasy that you get to paint with your own paint in a whole new way, which is the child that you're going to be creating with donor egg, but still an option that will help you complete your family. One thing that's important about this grief cycle is not to expect it to go in circles, and not to expect that if you've gone off one of these dots onto the next that you'll never backtrack. It's more like a ping pong ball, and it's really normal to ping pong all over the place. There are times when you feel that you're in the green zone, you've accepted things, and you're moving on, and you start to, and you've picked a donor, and you're feeling okay, and then the medication comes in the mail, and you feel like you freak out all over again, or you get mad all over again, or you're shocked. I can't believe I have to do this. And some normal times just to be aware of where the grief cycle can be like a ping pong game would be when medication comes in. It would be when you're picking a donor and you're sitting down there for the first time or for the third time, and you're looking carefully at these profiles, and all of a sudden, what am I doing? I can't believe this is my life. And even on the table on the day of transfer, that can happen too. And so there can be moments when you're just kind of saying, I can't believe this, and wow. Next slide, please. This slide I don't need to read to you. I think it's pretty self-explanatory, but the mixed emotions are what I want to key in on, that it's just so important that you understand you can proceed with mixed emotions. There are things you're not going to like about donor egg that will bother you, that do require some thinking, but then there are a lot of things that people really do like about the concept. And so it's okay to have some excitement and some trepidation and still proceed. Next slide, please. The question about how does my donor egg child fit into my family tree is one that I get a lot. And I just want to encourage you to remember that your family tree, everyone on it created you. And without you, you could not be a recipient for a donor egg. You absolutely are a key player, a phenomenally important person. The women that are going to be the moms are the people that are taking one cell that the donor gives you and multiplying it exponentially. You are not getting a baby. You are not sharing this child with anyone. There's no birth mom here except for you. So where does your child fit in on your tree? Right where any child would fit in that you bear on your tree. Because without your entire tree and all those branches, you wouldn't be able to create this baby. Despite using donor egg, still, I feel very firmly that this child is still very much right on your tree. And I joke with people, this is not a little shrub off to the side. This is absolutely coming straight down the line because you are involved in the creating process with your biology, your nutrition, your prenatal vitamins, your visits to the doctor to ensure the pregnancy is healthy, your nutrition, your oxygen, and so on. Your biology is at play. And the next slide, please. So how do they do it? I want to just give you a sense of how do people that choose donor finally choose donor. That's the big question. Eventually you come to a place where you are focusing on the experience of being pregnant and the experience of parenting, and that supersedes the genetic loss that you might feel. You finally come to the conclusion that parenting is going to overrule any loss that you feel about not using your genes and what that might be for you. So the experience of parenting has to win overall. The next piece is to really ask yourself, what is your definition of nature versus nurture? Some people will say intelligence is all hardwired and that's nature. Others will say absolutely you have to include the environment. Do you have the means to go to college? Were your parents nurturing around that particular musical talent or mathematic ability and so on? So nature and nurture are at play, and there's even more and more research being done on the epigenetics of the womb and how that turns on and off different chromosomes, which also make an impact on what is actually being genetically sort of triggered. So the environment in the womb is critical, and I think you do yourself a favor by learning and asking your own self kind of what's your line? What do you think around these two topics? And then you want to also ask yourself what's the gain and what's the loss, and see which way it tips. If you find that the losses are larger than the gains, it might behoove you to speak to other people that have done it, to find a support group, to go into a peer-led group with Resolve, to talk to a counselor, to find out are these losses truly nothing that can be that you can get over and live with and accept, or will they be permanent blocks that will keep you from doing this? Because a lot of loss is based on fear and a more narrow view of the parenting role. And so it's worth challenging. And lastly, get support. People that make this decision get support from their friends, from their family, from Resolve groups, from therapy groups, from counselors, from church, from their husbands and wives. And the less isolated you feel as you go through this, the more able you are to get perspective and make this difficult decision be a really great decision for your family. Next slide, please. That is my presentation. I know it's brief and quick, but I hope that it's jam-packed with enough information that you'll be able to help make decisions for yourself. And if not, you're welcome to contact me. I'm a mental health counselor in the Northern Virginia area. You can just look for my name. And I also host a fertility radio show called the Fertility Forum, and you're welcome to contact me there as well. And my email as well as Dr. K's are on the slide, and I believe will be posted with Resolve. Thank you. Thank you for the evening.
Thank you, ladies. Thank you very much for that. It was an excellent presentation. We really appreciate it. We do have one question from the floor that asks about how to select the donor. What can they see? Can they see what they look like? What information does the recipient obtain? And basically, I think the question really is how do I pick my donor and how much information can I get? So could either one of you answer that question?
Probably maybe if both of us comment. It's Dr. K here.
Sure.
I tell my patients that picking a donor is just a very individualized personal process. And it's not the same approach for every person. For some people, it's based on physical appearance, wanting to match a donor to be just like the patient. Many programs offer pictures, mostly childhood pictures. GIVF, we offer childhood and adult pictures. So that might be one approach. Another is based on, for example, education, wanting to know what their education is, their occupation, their SAT scores. Others, it's ethnic, religious, or racial background. Others, it's feeling connected to what they write in essays that they write. I have one patient who selected her donor because under a question in a profile that we had given a donor, under the question, what is your favorite song? And it was a very esoteric song, but it was the same kind of song that the recipient picked out, and she thought, that's a connection. Or questions to, other essay questions. Why are you doing this? What's your relationship with your family like? What's your relationship with God like? Feeling connected to the donors that way. For other people, it's just on a practical issue, who's your next available donor? Or I'm looking to do a cycle, and this timeline, who can cycle with me? So it really does depend, and it depends on what the patient and the couple are looking for. There's a wide variety of donors to choose from, and so it's just a matter of deciding what's important. For some people, they look to match characteristics. For other people, they're intrigued by other talents or characteristics the donor might have, and they find that appealing. So it does vary. Along the lines of that note, in the end, going back to the whole nature versus nurture, the only aspect that is a strong genetic trait that is predetermined, that the child will have a related outcome here, is a physical appearance. And so the physical appearance means more than just how someone looks. It has to do with eye color, hair color, facial structure. So that is something that will be passed on to the baby. Having said that, there are couples where a child looks nothing like mom or looks nothing like dad, and despite them both being biological parents. So there is definitely some wiggle room there. In terms of other things, there is no advantage in terms of picking one ethnicity. Again, sometimes we have some patients who pick donors from different backgrounds because the specific donor of their background is not available, and not a problem with that. There's no incompatibility between blood types or any other medical aspects. That's often another common question my patients ask me. And lastly, things like temperament, intelligence, personality. The thought is clearly there's a certain genetic component, but there's a large environmental or nurture component. And it is a woman's, blood and uterus that gives that embryo life. And so a lot of it, again, depends on other factors like Phyllis alluded to.
Phyllis, if you could hang on just 1 second before you respond to that question as well, if you could also include your response. I know you touched on it briefly, that do people tell their child that they came from an egg donor, and if so, at what age? And then we have 2 more questions to talk about. But if you could answer that one really quickly, that would be great.
Sure. Dr. K answered absolutely with regard to picking a donor. I wanted to add to the fact that some people pick known donors or they want to think about asking someone to be their donor for various reasons. And sometimes that's somebody that is in the family, a cousin, a niece, a sister, and other times it's a dear friend or someone that they know that they think would be a great candidate. And so in looking for a donor, even if someone has not offered their eggs, because that would make a known donor scenario, I certainly understand people wanting some of the tools in order to ask a person if they would consider donating eggs. And so when you're looking at all of your choices, do remember that some people do pick known donors because either the egg is offered or because they've asked and the person's been considered it and understood the whole process and ended up saying that would work for them. And that's just another sort of avenue that people go with donor eggs.
And then if you could address the question about telling a child that they came from donor egg and when.
Right. Overall, the earlier disclosure tends to be better. I say that if you're thinking about disclosure, that you want to think about doing it sooner rather than later, with the teen years being sort of and even the tween years being, let's not do it then. Let's have them know by then. Having said that, does that mean that you tell a 5-year-old or an 8-year-old or a 2-year-old? That you can really pick and choose on your own based on what is important to you. A lot of people say to me, I think maybe first grade, maybe a 6-year-old would understand privacy, so they wouldn't tell everyone at show and tell, but then they would also, not feel like they had this big sit-down talk. I think it's important to remember that you're going to be modifying how you tell your story. So if you're telling your infant that you're holding in your arms the story so that you get used to hearing yourself say the story, that can be a really great way. And, of course, you're not starting off with the whole story that includes your grief. You're talking about how great it is that your eggs didn't work and you were able to go to the doctor and get some help. So you can really simplify the concept, and absolutely you're focusing on the gift that you have in your child by saying, Mommy's eggs didn't work and we were so happy we got to go to the doctor because we were able to have you, and you can build on that through a lifetime. But do remember, disclosure is not a one-time discussion. It is a lifetime of discussing in order to be processed each step of the way as a child develops.
Thank you. Just a reminder, our webinar is supposed to be an hour long, and it's 10 after 10, so we've got about 5 questions going here. So what I'm going to do is I'm going to give the most common and I guess the broadest question. And if your question is not answered, the emails and the phone numbers for both Dr. K and for Phyllis are here on this screen. So please feel free to reach out to them, and they can certainly answer your question. 2 questions that are somewhat similar is, have any recipients had any regret after using donor egg and having a baby? And why don't we start with that?
Do you want to leave it at that?
Yeah,
Dr. K, do you want me to take that one?
Sure, go ahead, yes.
Okay. I've been doing this over 10 years, and I certainly counsel people before, during, and after. I have not seen any regret. I have not seen any lack of bonding. You don't get amnesia when the child arrives and just forget that you ever did this, but it really does shift from being a very big burden and a worry to different concerns that are parenting related. And so in my experience, I have not seen regret. I have certainly heard women and talk to women about, do you think about it still? And they'll say, it might pass mind, but it's just not a big deal anymore because I don't want to undo who I have, so I don't feel regret like I want to go back and change everything up because they are in love with their child. So will the thought come from time to time? Yes. Will it be as heavy and upsetting as it is today? No, it does not tend to be.
Thank you. Dr. K, really quickly, 2 questions on information that you provided. One, once they start the donor egg process, how will the recipient know that the donor has complied with all of the checkups, all of the medical treatment, all of the tests that they need to do? And then, how hard is it to find a donor that is of your ethnicity?
Right. Sure. The screening of the donor really depends on what facility or practice or agency you're working with. For example, all of our donors are fully screened, and so if you were to view our donors, all the testing that I discussed has already been done. Other centers or agencies might wait for you to select a donor, and then the testing is done. So that does vary. As far as other things in terms of compliance and so forth, again, that's where it's important just to work with a center that has a good reputation, has experience with donor eggs. There are ways of knowing the donor is complying with the donor is taking her medications appropriately. We expect certain expectations in terms of her hormone levels, follicle numbers. It's a very intimate process. The process of screening the donor, if it's done properly, involves at least 8 to 10 hours of face-to-face contact time, even before they start their very first shot. And through that period of testing, through the psychological evaluation, we do get a pretty good idea of, is this someone who is intelligent, is responsible, knows how to follow directions. And if for some reason, as we're in the cycle, things are not going the way they should, once again, we question, is she taking her medications properly? Is she following directions? So it's a pretty regulated system.
Okay, great. And also, could you just talk about the costs again, about what they could be?
That really depends on several factors. It depends on, is it, again, center by center variation, but in general, is it a cycle where every single egg is the donor's? Is it a cycle where the eggs are split? Are they fresh eggs? Are they eggs from a frozen egg bank? Generally speaking, it costs, several thousand plus dollars to do the cycle, so it's not inexpensive. Some insurances cover it. There are some options for money-back guarantee programs based on the center as well, or financing options.
And it's the recipient that's paying the costs to the donor and a fee to the donor.
Usually what happens is it's not a direct financial money transfer, and so what ends up happening is, as part of the fee that the fertility center charges, a part of that is the donor's fee, and the center pays the donor directly, unless it's a situation when it's a known donor, when in that case sometimes there is no compensation, or it's arranged privately. But any center you're considering, ourselves included, should have pricing information on the website, and or you can just simply call and ask for it and get it in detail.
Okay, great. One other question, and then we're going to close for the evening. Again, if you didn't get your question answered, you can certainly contact Dr. Gay or Phyllis at the information that's on the screen that you're seeing right now. Can you talk about a sibling registry for donor babies?
Phyllis, do you want to take that?
Yes, I can talk about that briefly. There is a registry, a donor registry, that was started by the adult the adult son of a single woman who used sperm donation. She and her adult son created a registry because, I guess, in their life they were wishing that they knew who the sperm donor was that created their family. It is sort of an unofficial thing that has blossomed and boomed, and the idea originally was sperm donors looking for the man that donated, if he wanted to go on and sort of say, yes, I'm number so-and-so, and I donated, in a California clinic and this time period, then they could match up if they wanted to do that. What has happened over the years is that people doing egg donation have done the same thing. So even though the donors said that they were preferring to stay anonymous and the recipients were preferring anonymity, they then have a desire to either know the donor or see if there are other families out there that use the same donor, because that would make the genetic children genetic offspring. And so I know that this happens and that this is something that some people feel very strongly about. They're very curious, particularly if people do not have a mother or father figure in their life. In other words, they've used sperm donation, but there is no dad, and they kind of get the two roles mixed up, saying, oh, your dad was a sperm donor. Well, no, that's really not the case. And the same thing for anyone that uses, donor egg, that it's not looking for your mom, because there is no other mom besides the person that's raising and caregiving and gave birth. The question around finding these siblings, if you will, and I quite frankly, I'm not so sure that that's the right way to really phrase it, is that people that use egg donor are also doing this because they value parenting over the genetic piece. So then to go and look for the genetic ties would be something to really consider before doing it. It certainly could be a pretty neat thing. It could also be a confusing thing. And I tell everyone that's considering that or any kind of disclosure, just to start very small and really ask yourself, what is the need to know? Because just because, as we know, there are genetics that are related does not make for a brother or sister or, the rapport and relationship that a lot of times people fantasize about. So the registry is out there, and it is for both donors of sperm and egg as well as the offspring, sort of just looking for some sort of connection.
Can you give us the website, or do you know what it is?
No, I don't know it off the top of my head, but if you put in donor registry, it'll
you can
pop
just
right
Google,
up.
Google donor registry. Great.
Yeah.
Thank you so much.
Mm-hmm.
All right. Well, again, thank you both for your fantastic presentation. We really appreciate your time. We also want to thank Genetics and IVF Institute again for sponsoring this webinar. Their support for this webinar allows Resolve to continue to provide a wealth of programs and services to those diagnosed with infertility. And again, we thank them for their generosity. For those of you attending this evening, thank you also for participating. Again, you can reach out directly to Phyllis or Dr. K with the information there. If you have any questions about the webinar, please contact me directly at dgannon@resolve.org or 703-556-7172. Again, my name is Dawn Gannon, and I want to wish everyone a great evening. Thank you so much. Have a great night.
Good night.
Thank you.